Now I will discuss antimicrobial stewardship in outpatient facilities and clinics. I would again emphasize that antibiotics should not be prescribed when they are not needed. For example, fever without evidence of infection, asymptomatic urinary tract colonization, viral infections, malaria, and inflammatory conditions where you can see that patient might be having some reactive changes in the joints and patient is having body aches and pains. So antibiotics are not needed in any of these conditions. Then we should also discourage the use of more broad spectrum antibiotics, like watch and reserve antibiotics should not be prescribed unnecessarily. For example, in surgical prophylaxis, we should use only those antibiotics which are particularly meant for that particular surgery. So unnecessary combination therapies, including certain fixed dose combinations, should be discouraged. Sometimes multiple antibiotics are used thinking that patient is having multiple infections, which is usually not needed, because it is not a rule that patient is having multiple infections at one time. So all those antibiotics which are having overlapping spectra, they should not be used in combination. So wrong antibiotic choices should not be made, and patient should have proper indication and specific infection for that particular antibiotic. Antibiotics should be prescribed with the proper dose, and there should be not even the overdosing, but also underdosing of the antibiotics should also be discouraged. Then wrong dose intervals are also very important. If some antibiotic has to be used thrice a day, they should not be prescribed for twice a day. And this has happened multiple times that even the diagnosis is right, the dosing interval was not proper, and this ends up with complications in that patient. So wrong route of antibiotic is also very important, because if we use antibiotic via a wrong route, it is going to end up in disaster. And wrong duration is also it is very important aspect, that if we give antibiotic for a wrong duration of time, the patient will be partially treated and either there will be relapse or patient will end up with a serious complication from that particular infection. Then delayed administration of antibiotic is also sometimes not justified. For example, if the patient is having a serious illness and patient is having sepsis and is going to be in septic shock, then one should not delay the use of antibiotic, because every delay in antibiotic use would end up in more morbidity and mortality. So core elements of outpatient antibiotic stewardship activity include commitment, action for policy and practice, tracking and reporting, and education and expertise. So the first core element of outpatient stewardship activity is commitment and leadership. It should display public commitments in support of antibiotic stewardships, identify a single leader to direct antibiotic stewardship activities in a facility, include antibiotic stewardship related duties in position descriptions or job evaluation criteria, and communicate with all clinical staff to set patient expectations. The second core element is action. One should use evidence-based diagnostic criteria and treatment recommendations. Use delayed prescribing practices or watchful waiting when it is appropriate. Provide communication skills training for clinicians. Require explicit written justification in the medical record for non-recommended antibiotic prescribing. Provide support for clinical decisions, and use call centers, nurse hotlines, or pharmacist consultations as triage system to prevent unnecessary visits of the patients. The third core element is tracking and reporting. Self-evaluation of antibiotic prescribing practices by the solo practitioners. They should participate in continuing medical education and quality improvement activities to track and improve antibiotic prescribing. Track and report antibiotic prescribing for one or more high priority conditions. Track and report the percentage of all visits leading to antibiotic prescriptions, and assess and share performance on quality measures and establish reduction goals addressing appropriate antibiotic prescribing from healthcare plans and payers. Fourth element is education and expertise. One should use effective communication strategies to educate patients about when antibiotics are and not needed. Educate about the potential harms of antibiotic treatment, provide patient education materials, provide face-to-face education training, and provide continuing educational activities for the clinicians, and ensure timely access to persons with expertise. Here there are basic concepts which I would like to emphasize, that there are 4 different things while prescribing antibiotics. One is called prophylactic use of antibiotics, the other one is preemptive, the third one is empiric use of antibiotic, and the fourth one is definitive therapy. So prophylactic use of antibiotic means the antibiotics are used to prevent any infection. Preemptive therapy means that you know that patient is going to have some sort of infection and we have to abort that infection. Empiric therapy is used to provide initial control of infection in the absence of knowledge or etiology of the illness. And the definitive therapy is that the culture report is backed with you and you know the etiology of that particular infection. So how important is to use empiric therapy in sepsis? The importance of choosing an appropriate antibiotic regimen for patient with severe infection is very important, because inappropriate therapy is associated with increased mortality and morbidity. Antibiotic therapy must be initiated as rapidly as possible, because every delay will end up with severe complications like septic shock, hypotension, and it will increase approximately 8% in mortality. So site of infection and likelihood of antibiotic resistance must be kept in mind, and we must identify what could be the likely pathogens depending upon the site of infection, and must implement source control. Before starting empirical therapy in sepsis, one must assess the likelihood that the pathogen is resistant to commonly used antibiotics by reviewing few very important aspects. What was the history of recent antibiotic exposure? Is there any known colonization with antibiotic resistant pathogens? What is the frequency of exposure of the patient to the healthcare facilities? And what is the antibiotic resistance patterns in that particular setting? Also consider host factors, which may include presence of life-threatening allergies to a particular class of antibiotic. One should also know that if there is an increased risk of direct toxicity with the use of an antibiotic, and if the patient is having marginal or unstable renal functions, and co-administration of interacting drugs. So these are all very important factors before starting an empirical therapy. So one should also assess the severity and trajectory of illness. How sick is the patient? How rapidly are they likely to deteriorate? What is the margin for error for us? If I give the wrong antibiotics, will the patient be alive tomorrow? And very important thing, one should ignore colonization and only treat infection, because there are various bacteria which are present on our skin, and they are just colonizers and they are not the true pathogens. We must be able to identify such colonizers and must not treat them, because otherwise we will end up using unnecessary antibiotics which will lead to resistance. One must obtain cultures before initiation of antibiotic therapy without causing inordinate delay in the institution of antibiotic administration. So what are the recommendations in sepsis? Effective IV antimicrobial therapy within the first hour of recognition of sepsis. One should reassess daily for potential de-escalation of that broad spectrum antimicrobial. Within 48 to 72 hours, one must conduct and document formal antibiotic timeout. And it is also recommended that the proper duration of antibiotic used must be implemented. One must treat most of the hospital-acquired pneumonias for only 7 days. Discontinue antibiotic therapy after 3 days in cases where daily ventilator settings are minimal. Discontinue antibiotic therapy early if there is 80% decrease in procalcitonin levels or it reaches a normal value. So there is always a dilemma that one would be thinking once a patient is there with sepsis, that whether I should start antibiotic, whether should I delay the antibiotic, which antibiotic to be used, what is the likely pathogen. So one has to identify the source of infection to narrow down the empiric treatment. And here comes the importance of appropriate antibiotic therapy, because we have to balance out whether the patient is going to get a benefit or the patient is going to get a harm with use of this empirical therapy. So it is always a two-edged sword, because it can increase in resistance while we are using a broad spectrum antibiotic. There can be an increase in the cost with their use, But at the same time, there is fear of losing the patient if we do not start the broad spectrum antibiotic in such cases. So one must always send particular site-specific cultures and think of de-escalation of empirical therapy once the culture reports and sensitivity data is back with us. So medicine is basically the science of uncertainty and an art of probability. One has to think in particular circumstances depending upon the factors which are relevant to the patient, which is a host, the bacteria, and the environment in which the patient comes to us.